Well, hello and welcome to this month's podcast, where, as always, we're going to bring you up to date with some of the latest data in the world of rheumatoid arthritis. What a wonderful world that is. Now, today's podcast, we're going to be reviewing papers by Chris Edwards and Yusuke Miyazaki, and we're going to be discussing baricitinib dose reduction in patients with RA, achieving sustained disease control, and switching to biologic DMARDs versus cycling among JAK inhibitors in patients with RA who are JAK inadequate responders. And it's an absolute delight for me to be joined by my dear friend and professional colleague, Professor Hans Bijlsma, Emeritus Professor over in Utrecht, who, as always, will give us his wisdom and insights. And I'm really looking forward to hearing those. Now, again, as always, if you want to access detailed summary slides for the papers we're discussing today, please visit imedforum.com. And with that, I'm going to hand over to you, Hans. Thank you.
So, I would like to discuss the paper by Chris Edwards and co-authors on baricitinib, the dose reduction in patients with rheumatoid arthritis, achieving sustained disease control, the final results from the RA Beyond study. On background, as you will know, baricitinib is an oral selective and reversible JAK inhibitor that modulates signal transduction of a variety of cytokines involved in the immune-inflammatory response. Baricitinib was approved for the treatment of moderately to severely active rheumatoid arthritis in adults who have responded inadequately to or who are intolerant to one or more DMARDs. In RA Beyond, patients achieving sustained low disease activity on baricitinib 4 mg were randomized to continue with dose 4 mg or to step down to 2 mg daily. The preliminary results showed that 80% of patients on 4 and 70% of patients on 2 mg sustained low disease activity at 48 weeks. The study examined the impact of dose reduction effects in patients with rheumatoid arthritis who achieved sustained disease control with baricitinib 4 mg daily up to 96 weeks in the completed Rheumatoid Arthritis Beyond trial. Now we move to the results. As hoped for, of course, demographics and clinical characteristics such as CRP, ESR, CDAI, and SDAI were similar between treatment groups. The step-down 2 mg arm had significantly lower low disease activity rates compared with continued 4 mg arm at 12, 24, 48, as well as 96 weeks, so all measurement moments. Patients who retained remission remained close to baseline, 38% over time. 70% of patients in continued 4 mg arm retained low disease activity, defined as a CDAI below 10 at week 96. Compared to that, 76% of patients in step-down 2 mg arm retained low disease activity at week 96. The dose reduction to 2 mg resulted in a statistically significant increase in CDAI, SDAI, DAS28 CRP, and DAS28 ESR. Most rescued patients regained low disease activity, including remission after rescue to baricitinib 4 mg 24 weeks after rescue in the DMARD irresponsive group. Step-down emergent adverse events, infections, serious adverse events, and serious infections were higher in patients continued baricitinib 4 mg compared with step-down 2 mg. So these data lead to the following conclusions. Quite obvious, I think. The majority of patients retained low disease activity following dose tapering or regained it with return to 4 mg. Some patients who achieved sustained disease control with baricitinib 4 mg but were dose tapered to 2 mg showed increased disease activity. There were lower incidences of treatment emergent adverse events in dose tapered group compared with continued baricitinib 4 mg. And of course, as always, the decision to dose taper should be part of the shared decision-making process between the patient and physician, considering the balance between risk and benefit. For me, for daily practice, it will mean that it is quite possible to decrease the dosage of baricitinib in a trial to find out whether the individual patient will be able to respond adequately to it or not. And when it's not responding, the patient is not responding, then it has been proven that increasing again to 4 milligrams in nearly all the patients brings back the low disease activity. So I think this is a very positive study and a clear conclusion.
Hans, thank you so much. As ever, crystal clear and all of the salient details presented with beautiful clarity. So it leaves me with the unenviable task following that, and I'm going to talk a little bit about the second paper, which is switching to biologic DMARDs versus cycling among JAK inhibitors in patients with rheumatoid arthritis and with inadequate response to JAK inhibitors. Now, this is the first registry, FIRST, first registry. Now, basic background here, well, you know there are 5 JAK inhibitors available for use in people with RA. A minority of patients with RA will exhibit an inadequate response to JAK inhibitors, but it's still a significant number. And cycling to another JAK inhibitor in those patients could potentially result in a higher drug retention rate within class as compared with switching to biologic DMARDs. But that's self-evident, but it doesn't necessarily make it right. And we don't know which molecular targeted drug is more effective in patients with RA with an inadequate response to JAK inhibitors. So this study determined the characteristics of patients with, first of all, an inadequate response to JAK inhibitors and identified molecular targeted drugs appropriate for these patients. So key results were as follows. Patients with JAK inhibitor resistant RA exhibited a lack of response to multiple biologic DMARDs before commencement of the JAK inhibitor treatment. So that's straight away quite an interesting challenge in how we would design and interpret. Factors associated with inadequate response to JAK inhibitors were suboptimal JAK inhibitor dosing and higher HAQ disability index scores. The retention rate at week 26 after drug switching was 87% in the group that cycled to other JAK inhibitors and 75.6% in the group that switched to biologic DMARDs, although there was no significant difference observed between the groups. CDAI significantly improved from baseline to week 26 after drug cycling and continued to improve until week 26 in the group that cycled to another JAK inhibitor within class. CDAI score overall was lower at week 2 and week 4 after drug cycling and was significantly lower at week 26 in the group that cycled to another JAK inhibitor. And the rate of CDAI-LDE achievement and CDAI remission at week 26 were significantly higher in the group cycling to another JAK inhibitor compared with group switching to biologic DMARDs. The trajectory of changes in CDAI after drug switching were kind of interesting. The best fit was achieved by dividing into 3 groups. Group 1, patients who had high disease activity at baseline and showed no improvement in disease activity despite switching to molecular targeted drugs. Group 2, patients who had moderate disease activity at baseline and showed only partial improvement in disease activity despite switching to molecular targeted drugs. And group 3, patients who had moderate to high disease activity at baseline but showed prompt improvement on disease activity after switching to molecular targeted drugs. Although no difference was observed in group 1, group 2 was higher in those switching to biologic DMARDs than in those cycling to other JAK inhibitors. And overall changes in the CDAI of all patients with JAK inhibitor inadequate responses after drug switching classified into trajectory groups, showing that the proportion of patients in group 3 was higher among those cycling to another JAK inhibitor than in those switching to biologic DMARDs. So this tells us that cycling JAK inhibitors may be more effective than switching to biologic DMARD in patients with RA and an inadequate JAK inhibitor response. But we've got to be really, really careful. Remember that a lot of these patients exhibited a lack of response to multiple biologic DMARDs before commencing their JAK inhibitor treatment. So I think my take home from this study, more work required. I think it's an interesting question. It highlights the importance of the question, but we really need to think very carefully about the design implications for the strength of interpretation that we can draw. So interesting study, interesting data, more work required. Well, look, that's what we had to talk about in our podcast. And as always, to view the full publications uploaded this month and to access all our other podcasts and resources, and there are now many of them, head over to imidforum.com. IMIDforum, all one word, IMIDFORUM.com. It's a treasure trove. I hope you enjoy what you find there. I certainly use it. The slides, I have to say, are a terrific resource. Don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel, and make sure you don't miss our podcasts in the future by so doing. And finally, before closing, let us know what you think by leaving a review. So, a couple of words of thanks. First of all, to you, Hans. Absolute pleasure to have you with me for this podcast. As always, I've learned from you, and I know those who listen to podcasts will learn too. And thanks to you, our listeners and viewers. Thanks ever so much for your attention. I hope this is useful to you, and I hope, above all else, that it helps us in our journey to treat people with rheumatoid arthritis, which is why we're here. Thanks very much. Stay well.